One of the things that I'm very interested in is doing pre-procedural planning using imaging to help interventionalists or electrophysiologists improve their way of delivering therapy. So this particular study is looking at how we can use newer CAT scan, the newer advanced technology of CAT scans, and see if it could predict whether or not someone who has a cardiac resynchronization therapy device and see how it can improve who responds and who does not. Well, there are three main factors that affect whether or not someone responds to CRT or not. We all know that in general it works. The main issue is that about 30% of people who get these devices actually do not respond. So researchers have been trying to figure out why people do not respond to this device therapy that is life-saving. So the three main things is, whether or not they have dyssynchrony, whether or not they're scar, because if you try to put a lead on scar, it doesn't pace. And then the interplay between lead placement and scar and location of latest activation. So what we found was that when you look at 6-month CRT responders in terms of hospitalization, et cetera, there's actually no parameters that predicts, no CT parameters that predict CRT response. But that's consistent with the echo data, actually. But then we also found that there are 2 CT parameters that predict 2-year MACE. And I think this is actually a really nice outcome because it's a harder outcome. So it's this global wall motion parameter as well as a segmental one. So these 2 CT parameters can actually help predict who would have a 2-year MACE event. The other thing that we wanted to look at is to see the location of the lead location based on the response and how that affects. So we look to see if the lead is located at the region that contracts the most, or it contracts the latest, and we found that if the lead is placed in the region that contracts the latest, patients are less likely to have an event. And the last thing we wanted to do is, because cardiac CT, one of the benefits of CT is that you could also assess the coronary venous anatomy, is that we wanted to see if it reduces implantation time if we randomize patients to showing the images before to the implanting physicians, and those we don't show. And then there actually was no time difference. And then we looked at one last thing, which is how does scar affect whether or not someone respond or not? And we actually found no scar, that scar did not affect CRT response. Right now, none. There's no gold standard. So I think this actually is very promising because it opens up a new research avenue that we can go and target using CT as a more personalized approach. Because what our findings are, I think we need to do larger studies, multi-center studies, because this one is a single-center study. We need to do larger multi-center studies that is powered to look at the MACE event. And there's a lot of potential for software development to improve throughput. And then the idea is to get a targeted approach, a more individualized and personalized approach to delivering this therapy to improve how patients respond to the device. One of the reasons and one of the drawbacks in the past has been what's called temporal resolution. Temporal resolution is, spatial resolution, there's 2 components, right? There's spatial resolution, is point A and point B, and the difference between seeing the 2 together. So if they're this way apart, you see as 2 dots, versus if the spatial resolution isn't good, you see it as 1 dot. Now, temporal resolution is through time, point A moving to point B through time. So it's like shutter speed of a camera. The older CAT scanner, the shutter speed is slower. So you can stand still and take a picture and it's blurry. the new dual source scanner has two detectors 90 degrees apart, and so the temporal resolution is much better. So shutter speed is better. So when you're running, you could take a picture and you get motion-free images. So sort of like the way the iPhone works, you know, like back in the days, you have to stand still and then it still can be blurry, but now you can be moving and it still looks great. The take-home message essentially is that it's not over yet. We shouldn't give up on doing research to help improve these patients. You know, we wouldn't want to do a study and say, oh no, you cannot get this life-saving therapy. But what we need to do is do research to improve delivery of the therapy, to personalize, you know, the individual, because not everyone's coronary venous anatomy is the same. Not everyone's location of scar is the same. So how can we deliver this device to the patient so that they can have personalized CRT is what I like to say, you know, and that way, you know, it gives them the best chance of having their response. This one is a single center study. We'd like to do a larger multi-center study that will allow us to also do more software development, you know, to improve the throughput and make the delivery system much better.